Mr. Roy, you're up next. Welcome.
Thank you, Chairman Brady, Ranking Member Levin, and members of the Ways and Means Committee. Thanks for giving me the chance to speak with you today about the tax treatment of health care. In my remarks today, I'll focus on three areas. First, I'll discuss how the tax treatment of health care is the central flaw in our health care system. Second, I'll address arguments made by opponents of health tax reform. Third, I'll discuss the principles of sound reform. Republicans and Democrats may occasionally disagree on health care policy, but we all agree that health care needs to be more affordable. Nearly all of the growth in future federal spending, and thereby future tax increases, is driven by health care, in particular health care inflation. And the high and rising price of health care is the reason we have so many uninsured. According to the CBO, 98% of the long-term uninsured cite the high cost of health insurance as a barrier to coverage. Only 6% cited poor health status, such as a pre-existing condition. The median worker's paycheck has barely increased in 3 decades, but overall compensation has grown. The problem is that most of the growth in compensation has been eaten up by the rising cost of health insurance. In 1996, the cost of coverage was 11% of per capita income. In 2010, it was 19%, nearly double. The high cost of U.S. care originates in 1940s wage controls, as you know, and is enshrined in the employer tax exclusion. Hospitals, doctors, and drug companies have a powerful incentive to charge high prices here because the exclusion from taxation of employer-based insurance prevents patients from controlling their own health care dollars and thereby holding companies accountable for the prices they charge. Today, the employer tax exclusion, its value in terms of federal, state, and local income taxes and federal payroll taxes exceeds $500 billion a year. So it's extremely important to handle reform of the exclusion with great care. But that's different from opposing reform altogether. If we want to make health care affordable, done properly, we have to reform the exclusion. Health tax reform the right way would put more dollars in the pockets of workers rather than insurance companies. Some opponents of health tax reform say that employer-based coverage protects us from single-payer health care. That is manifestly untrue. The rising cost of employer-based coverage has actually been the principal argument for every major expansion of government-run health care in the United States. Switzerland, by contrast, has a market-based system in which everyone purchases private coverage on their own, individually. That system isn't perfect, but it's been a far better check on the government. In 2014, the Swiss rejected a referendum to replace their system with single-payer health care by a margin of 62 to 38%. People like choosing their own plans and will never allow the government to take away that right if they control it. There are 2 keys to high-quality health care reform, health tax reform. The first is that any reform should give workers more options to buy the coverage that they want. The second is that reform should be enacted gradually. The ACA's Cadillac tax resembles such reform by taxing high-value employer coverage, but that tax contains many exceptions and does not deploy the revenue it raises to aid all those who would like to purchase insurance on their own. The best way to expand health insurance choices for individuals is to truly equalize the tax treatment of employer-purchased and individually purchased coverage. Congress could design a cap that raised an equivalent amount of revenue as the Cadillac tax, gradually phased in over time, while also providing tax relief to those who purchase coverage on their own. There's wide bipartisan agreement on the utility of refundable tax credits for expanding coverage to the uninsured. The ACA, of course, deploys tax credits for this purpose, but that law has imposed costly mandates on insurers and individuals that have made coverage less affordable for millions, especially those ineligible for subsidies. Some say that we should offer Americans an identical tax credit to every American with which to purchase coverage. But such a system would necessarily under-subsidize the poor, the sick, and the vulnerable, while over-subsidizing the wealthy. Tax credits for the uninsured should embrace the best of both worlds. They should be means-tested to best help those in need. They should apply to health savings accounts and maximize the ability of people to choose the care and coverage that's best for them. In this way, we can achieve the goals that every member of this committee shares, ensuring that every American has access to quality, affordable health care. Thanks again for having me. I look forward to your questions and of being of further assistance to this committee.
Thank you, Mr. Roy. We talk about the tax code being stuck, in the past because it's been 30 years since we reformed it. But this tax incentive actually first appeared in 1918, got serious 70 years ago, and effectively is stuck there. But workers aren't stuck. Many of them change jobs multiple times throughout their life. Many will go home to start a small business. Others choose to want health care individually so they can raise their families. How, in your view, is it appropriate to modernize that tax incentive at work to be able to create that flexibility for workers to live a 21st century life, because frankly their lives are different than when this first got serious 7 decades ago?
Absolutely. I would make 2 points. The first point is that employer-based tax reform or health tax reform is not about having workers pay more. It's actually about workers paying less for their health care. All of these efforts are about making sure that workers pay less for health care and that health care is more affordable in the future than it is today. And the second point that I'd make is that what's really important, aside from making health care more affordable, is putting patients and workers more in control of their own health care dollars. Today, those health care dollars are controlled by the government, by employers, by insurance companies, by hospitals, by drug companies. They're not controlled by the consumer, by the worker, by the patient. And all of our efforts on tax reform are about putting the control back in the hands of that individual and those families.
What's the best way to modernize this tax incentive at work, and Mr. Roy as well, that creates that flexibility for Americans to control more of their health care plans? Mr. Roy?
I think
Yeah, I would agree with my colleague over here, Mr. Antos, and I would add that one of the important things about giving people that choice to buy the health insurance and the health care that makes sense for them is the profound innovation it would trigger in the healthcare system. Today, in most states, one health insurance company has 80% of the market. And that makes it very, very difficult for people, even if they do choose their own health insurance, to have true choice. But if you actually give people control of those healthcare dollars again, give it back to them to spend the way they want, you'll see profound innovation and competition in not just how health insurance companies have to compete with entrepreneurs, but also how health insurance should be used versus health savings accounts, versus urgent care, versus all the other things that are out there. So people should have those choices, and we won't be able to anticipate how the consumers, how individuals will decide to use those dollars in the future, but it will be much better than it is today. That we can be very confident of.
Medicaid provides coverage for more than just poor people. Mr. Roy, do you favor continuing Medicaid?
Yes, if you want to know all about the details of my own views on health reform and how to achieve universal coverage, I've published them at the Manhattan Institute.
Okay, I understand that, but you favor continuing Medicaid?
Yes. What we need to do, though, is dramatically reform Medicaid, because right now, health outcomes for people enrolled in Medicaid are no better than people with no insurance at all, and that's because the system is so poorly designed. So reforming Medicaid is essential to providing high-quality health coverage to the poor.
So health care under Medicaid is no better than for people who have no health insurance at all?
According to the New England Journal of Medicine, which published a study looking at Medicaid enrollees in Oregon, people enrolled in Medicaid showed no better health outcomes than people with no insurance at all.
They were talking about outcomes. That was one study. That doesn't mean that people...
There are many other studies.
Okay, that people who have Medicaid are no better off than people who have no insurance at all.
Well, just to be very clear, I support universal coverage. I support health coverage for the poor. I think we should do it in a very different way.
whether it's a Medicaid patient who can't get in to see a primary care doc and ends up in the emergency room in Columbus, Ohio, or my mother-in-law who's going to a rehab facility, the patient is excluded from the cost of the care. How do we get patient-centered care and patients focused on the cost so there's not overutilization, so that there's more transparency, and all of us know that there's just not some tree in the backyard we're pulling money off of, and we don't have any competition.
The only way to have patient-centered health care is for the patient to control the health care dollars. We don't have patient-centered health care today because employers and insurance companies and the government controls the dollar. And that's why we have government-centered health care, not patient-centered health care. I want to bring up a point that was brought up earlier about Switzerland and how it allegedly has regulated prices. What it has is insurance companies can jointly negotiate prices with hospitals and drug companies, and that's a system, I've written about this for Forbes, we could have here. All you have to do is have an antitrust exemption for those kinds of negotiations for private insurers in Switzerland or in the United States. So there are market-based systems elsewhere that we can learn from, but you're never going to have a patient-centered healthcare system unless the patient is controlling the dollars.
And you're for quality health care.
Absolutely.
Thank you.
And again, I've written about this extensively. I would encourage anyone who's interested in a detailed plan on health reform
I yield back.
to download it from the Manhattan Institute or from the American Enterprise Institute, for that matter.
Thank you. Mr. Lewis, you're recognized.
Thank you very much, Mr. Chairman. Thank each one of you for being here this morning. I would just like to know whether you believe in health care as a right. In a country such as ours, health care for all. Do you subscribe to that idea?
Who is the question addressed to me, sir?
Any of you.
First, let me just say, Mr. Lewis, it's always a pleasure to speak with you. You're a personal hero of mine. I support universal coverage. I think, like many of your colleagues, a country that is as wealthy as ours should strive to provide quality health coverage for every American. But the way to do that is to maximize the degree to which individuals are controlling those health care dollars and subsidize through tax credits, through refundable tax credits, those choices for those who need the help.
What can we do to encourage more consumerism? And I mean, I don't want to take coverage away. Another concern that I have, and there is this push to expand Medicaid, all the while we know that it pulls people off of private pay in some cases, and Medicaid provides lower reimbursements to hospitals and doctors, and so it becomes this vicious cycle that who loses? Consumers, patients, and drives up the debt and fewer choices that are out there. What can we do to encourage more consumerism? Mr. Roy?
Yes, so again, I would say that the biggest thing that you can do to encourage consumerism is to have the patient control the healthcare dollars. The reason why we don't have an Uber for healthcare, or we don't have the kinds of technological innovations that have changed the rest of our economy, why is that not happening in healthcare? It's because those things can only happen when the consumer can direct his or her dollars to the healthcare service that he or she needs. When the government or the insurance company or large employers control those dollars, then the consumers aren't involved in those decisions. So you have to have the patient in charge of the healthcare dollars, and health tax reform, which this committee is considering, is the central key step to achieving that goal.
Another major concern is that employee contributions to their health care through an HSA are counted toward the cost of care that is measured against the Cadillac tax threshold. Likewise, spending on wellness is also counted. Can you tell me why?
Yes, so this is one of the major design flaws of the Cadillac tax is that it's designed effectively to prevent people from having more consumer-based health insurance plans. HSAs are inhibited by the Cadillac tax. As you noted, wellness programs are somewhat inhibited. And also there are a number of loopholes and exceptions in the way the Cadillac tax applies to different constituencies, different employer groups, and different areas of the country. So it would be much cleaner to have a gradually introduced cap on the employer tax exclusion, as some others and we have discussed today, so that it's a simple system that applies fairly to everyone. The challenge is if you heavily vary the tax deduction or the tax exclusion based on particular regions of the country, you might actually have the perverse consequence of rewarding high regulation states that drive up the cost of insurance in their states.
So why was
because
it
they don't face the tax consequences.
Do you have any idea why it was designed this way?
I wasn't in the room when the Affordable Care Act was
What would be
designed, but I understand that various interest groups lobbied for exceptions and changes to the Cadillac tax so that it could serve their interests better.
Thank you. Mr. Bracero, you're recognized.
Thank you, Mr. Chairman. Gentlemen, thank you for your testimony. Let me see if I can run through a few areas. And first, Mr. Antos, to you, Mr. Roy. I understand you all have put together the elements of a plan that could be an alternative to the Affordable Care Act. Have you ask that that be placed in legislative writing so we could actually see it as a form of a bill?
It's a plan, there's two plans. There's a plan that Mr. Antos and I collaborated on with some other colleagues that was published by the American Enterprise Institute. I think there were 10 co-authors, if that's the plan you're referring to. Then there's the one that I published through the Manhattan Institute individually. Neither of those plans has been introduced as legislation or put in legislative language, but our hope is that it may happen at some point.
Do you have any supporters on the Hill, on the House or Senate side for either of those two plans?
I think that a lot of the general concepts are being considered in a lot of the working groups that the Speaker has organized.
So we're 6 years past the enactment of the Affordable Care Act. We were told by those who objected to the Affordable Care Act, didn't vote for the Affordable Care Act, that we need to repeal it, get rid of it, and replace it. We have yet to see a proposal in legislative language that's been able to garner any kind of support that could pass to replace the repeal of the Affordable Care Act. And I'm wondering if can you name any member of Congress who is ready to endorse by submitting your plan into legislation?
What I would say is that
can you name me a member in the Senate or the House who's prepared to endorse?
I'll volunteer.
I'm sorry?
I'll volunteer.
Okay, so Mr. Price is willing to introduce your plan. So you've got a taker. Will you submit it to Congressman Price so he could submit that into legislative writing?
Sure.
more than happy to work with Dr.
Great.
Price. and
It'll be,
any
so this way we can actually have something to compare, because we'll need to have the Congressional Budget Office, Joint Tax Committee, everyone do the analysis so we can see what we're talking about, because until then, we're talking apples to oranges. We want to see what your apple looks like. We see what the Affordable Care looks like. 20 million Americans today, as a result of the Affordable Care Act, have health access, health insurance. And I think for those who kept saying that it was going to cost us jobs, in the time that the Affordable Care Act has been in place as a law, we've had close to 1.7 million Americans go to work or go back to work, not overall, just in the healthcare sector. Overall, some 14 million Americans have gone back to work. So it's going to be interesting to see what your plan, once it's scored out, really shows us. And I hope,
Would the
hope you
gentleman
can show us
yield?
that. Certainly a yield.
Dr. Price, I'd like to join with you in co-sponsoring this fictitious plan that has been out there for 6 years. And if it can really help the Republicans to come up with something, Mr. Roy, would you contact my office and Dr. Price's office so that we will get some legislative language to know exactly what you're talking about?
That'd be
It
great.
would
I'm
truly
going to
be an
reclaim
honor,
my
Mr.
time.
Rangel.
Mr. Roy, you could talk to Mr. Rangel afterwards. I want to reclaim my time so I can ask a couple more questions. Mr. Antos, Mr. Roy, so I suspect your plan, I've seen some elements of it. So high deductible with HSAs, you trying to make them a little bit more robust. Those are parts of what the plans typically include? Well, I'm not trying to name everything. I'm just,
You could choose a
an
high
option.
deductible plan. So the key element is
okay, and
choice.
I don't want to get into all of it, but I just want to make sure it does rely to some degree on high deductible plans.
No, that's not correct.
No. Okay, I apologize. Do you support high deductible plans?
As a choice, yes.
Choice. Okay, and let me ask this. Would you support high deductible plans with access to an HSA, health savings account, because that typically is the way they are packaged, right? So you can make the most use of them. For seniors under Medicare?
Yes, I think that's a feasible possibility, too.
Mr. Roy?
Yes.
Okay. Final question. I think Mr. Kreisberg answered the question about whether you believe health care is a right in this country for Americans. I don't think I heard you say yes or no. If it's not a right, then it's obviously then a privilege that we can try to get access to. Do you believe it's a right?
Yeah, let me tell you a story that
No,
explains this.
I don't have time. I
No,
got 11
because
seconds.
healthcare is
No,
a right,
I don't
but
have
you
time
to
for a
understand-
story.
You have to
could just say,
understand what healthcare
Mr. Roy,
is.
Mr.
You
Roy,
have to understand
if
what a right
you don't
is.
wish to answer the question, that's fine.
Yeah.
But
Well,
I just asked a question, yes or no?
I refer you to an article I wrote for Forbes called "Yes, Healthcare is an
Antos?
Individual Right."
Mr. Antos? Yes
All
or
time
no?
has expired.
Mr. Chairman, if I could just
Dr.
ask him to answer
You're
the
right.
question.
So I think let's explore this concept a little bit about the injection of personal responsibility. Mr. Roy?
Healthcare is a right, and what I mean by that is that it's the right of individuals in this country to choose the health care that they want, to choose the health coverage they want, to choose the doctor they want, the nurse they want, the form of urgent care that they need. Those rights have been abridged by Congress over an 80-year period. And if we believe that health care is a right, then we have to maximize the ability of people to control their own health care dollars, not the government, not insurance companies, not employers.
The health benefits consulting industry knows the easiest thing to lop off if you're faced with that is an HSA.
Yeah, and didn't it require that you have to have a prescription now if you want an over-the-counter prescription to use one of those accounts? Limiting these types of structures or accounts, as Obamacare does nothing to help keep healthcare costs down. If more Americans were empowered to manage their own healthcare decisions and had more skin in the game when it came to their healthcare cost decisions, then what would you predict the impact to be on our healthcare spending, Mr. Roy?
I'm sorry. Well, let me just
Mr.
say
Antos,
quickly
sure, go ahead.
that the added complications will only make it more difficult for consumers to operate in the way that we would like them to do, which is efficiently.
It would reduce costs and increase choice and increase quality and increase patient service, customer service. Customer service is lacking so much in our healthcare sector because the patients don't control the dollars. The government does, the insurance companies, the employer does. So everyone orients and caters to them, not to the patient.
Thank you.
So one of the things that's important I want to mention, because it's been raised a number of times by one of my colleagues here, is this idea that consumers are incapable of making healthcare choices, that if you're unconscious because you've had a stroke, well, you can't choose your hospital. That's true. That's the proper role of health insurers, to negotiate those prices and those networks on your behalf. But there is an enormous ecosystem of healthcare choices that we can make on our own. The choice to which eye doctor you go to, who you get your primary care from, whether to get knee surgery in your state or a neighboring state from a low-price center or higher quality center. There are an enormous range of choices that can be opened up to patients to make for themselves, and there can be no doubt that they will make those choices better than the government or their employer. There was a study done last year that showed there's enormous price variation for common procedures that all of us often use. But we have no transparency into how much those procedures cost because none of us are in control of our own healthcare dollars. So the more patients are in control of their own healthcare dollars, those prices will come down massively because providers will have to compete for patients' business instead of the other way around.
Great point. One particular limit that is in Obamacare that obviously has me concerned is the over-the-counter drugs. They were designated as qualified medical expenses by the IRS in 2002, yet Section 9003 of the Affordable Care Act mandated holders of tax-preferred accounts like FSAs and HSAs seek a doctor's prescription in order to be reimbursed for purchases of these OTCs. How does requiring a script for products the U.S. FDA has already determined safe and effective for over-the-counter use, and the IRS has determined to play a key role in healthcare delivery, improve customer choice and access to healthcare?
This was one of the least rational provisions of the ACA, to force you to go to a doctor to obtain a medication that is available over the counter. That's the kind of thing that drives up healthcare costs, and it was solely done as a revenue-raising measure to pay for the ACA's coverage expansion. That would be a great example of something that this committee could do something to reform.
Great, thank you. I yield back.
I think this is moving in a positive direction, and we also, with the bill, will make sure that we are going to be expanding what the accounts can be used for, as Ms. Jenkins had mentioned, for instance, but we'll be able to include preventative care prescription drugs, health insurance premiums will be included, over-the-counter medications without that doctor's prescription, physical fitness programs, so wellness, nutritional supplements, and membership fees for innovative direct primary care models. So clearly, these accounts can be a key solution for everyone who is dealing with higher health care costs. And, you know, Mr. Roy and Mr. Antos, I know you've written a little bit about this as well. You've talked about it. Anything else you want to just share about the importance of these accounts and how we should make this a highlight of the reforms where we're trying to go?
You've made a lot of great points, Mr. Paulson. One I would emphasize in what you alluded to is that health savings accounts have the potential to transform health coverage for the poor. Imagine if we took the cost-sharing subsidies that are in the ACA and converted those into health savings account deposits. That means if you're sick, you can use that HSA deposit to pay off your deductible. But if you're healthy and you stay out of the hospital, that HSA can accumulate and roll over and generate compound interest. And over time, that person who today is low income with negative net worth can actually have a positive net worth, pass that nest egg off to their children. And you actually can transform the entire economic trajectory of that family and future generations of that family. So that is the power of health savings accounts. They can do more for poor people than any other approach to health reform.
Mr. Roy, I want you to answer this for me. What happens if a person currently with employer-sponsored insurance loses their job? Can they keep their plan?
Well, they can have COBRA for 18 months, but it's very difficult to transfer that coverage to individually purchased insurance. There's a gap in the transition. They don't have the ability to protect the exact plan they had before.
So that brings up a really good point, is that they have COBRA, and I have constituents who are in this situation. Let's just say that the employee does get the COBRA, but their benefit value for their plan was $3,000. That's probably even low, consider what insurance really costs today. But does that employee get to take that benefit with them while they search for a new job and take that $3,000 so that they can help pay their COBRA?
I don't believe so. I mean, I think it depends. Joe might
Mr.
know the
Anthos?
answer to that.
Yeah. I think the answer clearly is no. At least that's what I'm learning from my constituents. So you have that insurance, but it's not really portable because you can't afford the COBRA. Many people will tell me, I can't afford the COBRA. Yeah, it's there. It's a benefit for me, but I can't afford it. So we put them into a difficult situation where they had employer-sponsored insurance, but they don't really have an option there when they leave it because it's really not portable. So for all the benefits of the employer-sponsored based system, which there are many, and I'm not at all saying they're not. One great drawback is this, that if the employee loses their job, then he or she loses support for the purchase of their health care insurance. If we were to design from scratch a health insurance system, then how would you mitigate against this profound loss? Mr. Roy, you want to answer that?
Yeah, you know, one analogy that was made earlier, one comparison that was made earlier today was between auto insurance and health insurance. And I think that's a really great way to think about what health insurance should look like. We don't expect auto insurance to pay for our gasoline or oil changes or our wiper fluid. We expect it to protect us against catastrophic financial loss if our car gets totaled, it gets stolen, it gets crashed, we get into an accident. That's what health insurance should be. Health insurance should protect every American from bankruptcy due to medical bills. But the moment we expect it to dominate all of our health care choices is the moment that it becomes too expensive. And to your point, we don't ask our employer to sponsor our car insurance for us. That would be completely irrational. And similarly, it would make a lot more sense to have individuals have the ability, the option to choose their own health insurance. Now, there are arguments for employer-sponsored health insurance. It should continue because there's a certain scalability. If you have a large group with 300 employees, the ability to purchase health insurance that's more affordable for that population is greater sometimes than if you purchase it for your own. But that shouldn't just be about large employers or even small employers. That should be your church group. That should be a professional association. That should be any group of people that wants to get together to pool their risk and pool their options.
So there are other options out there which we should be speaking about. And just to conclude, if you have somebody who is on the Affordable Care Act, they really don't have a lot of choice either. And that is not portable either, because if they want to take those subsidies that they get from the federal government and purchase something outside of the system that they're required to use, they don't have that choice either. So
let me make an analogy there that the choices in the Affordable Care Act are you can buy a car from GMC or Honda or Ford or Toyota so long as it's a green pickup truck.
I just want to read to you. A subsidy is a sum of money granted by the government or a public body to assist an industry or business so that the price of a commodity or service may remain low or competitive. My question to each of you, who supplies the money for the subsidy?
In both cases, it's the worker. right? So Mr. Kelly, you had said that.
I'm with you. It's okay.
That I don't.
Mr. Kreisberg,
I don't pay
I'll come back to
I
you,
pay
Mr.
for
Roy.
it because
I'll come back to you. I understand. But who pays for the subsidy?
If you're talking about
I'm talking about subsidies.
the advanced premium tax credit on the Affordable Care Act
I'm talking about where does the revenue for the subsidy come from?
comes from the taxpayers.
Taxpayers.
Right, from the taxpayers.
It's all generated by hardworking American taxpayers. It's not generated by the government. The government looks at every single dollar we make and says, here, we're going to allow you to keep a fractional part of what you earned. The government says to every hardworking American taxpayer, we are going to allow you a portion of each dollar that you earned. The government will take from taxpayers the amount of money they need to run programs and say, we will use it better because we know how to use it better, but you will supply it. Am I wrong on that?
No.
Okay.
And one thing about the employer tax exclusion that is.
Listen, I'm running out of time, Mr. Roy, and I don't want to give a lecture,
Government
but I
is
want to get down. The purpose of
steering your
this meeting was to talk about tax expenditures and capping what an employer is allowed to deduct. I happen to be in a private business. I have always provided health care for my people. Now I'm being told that you're not going to be able to deduct that as a cost of doing business because you've actually gained that in order to avoid paying taxes. And the people, and by the way, the people that receive that benefit, they should be taxed on that because that was actually revenue. We're trying to adopt some source of revenue from hardworking American taxpayers again. All of this stuff is being driven by taxes.
It's not to raise taxes. It's actually to lower taxes.
Mr. Roy?
Increased out of pocket.
Mr. Roy, do you pay tax on your health care plan?
Yes, I do.
Do you really?
Absolutely.
Okay, it's provided by the agency you work for.
We all pay taxes.
You pay wage taxes.
Our taxes pay for the cost of our healthcare system.
Okay, I get that part. I get that part. Listen, I understand
The
that.
American people, if they watch this, they would get very frustrated. And as my friend Mr. Larson said, they get frustrated, but it's not because we're talking about they get frustrated because we're talking at each other instead of listening. And that's the problem. We need to listen to our witnesses. We need to listen to the people we represent. So I'm going to go back. Employers, I'm glad that Mr. Kelly got us back on track as to what the hearing was about. You know, employers cover, this per the CBO, 63% of health care through employer-sponsored plan. You guys would agree with that, right?
The worker is paying for that because it's part of the worker's overall compensation.
I understand.
The employers,
but employers are covering.
Part of when an employer hires someone, the cost of their overall compensation.
We're going to get to that.
Calculated.
Crazy. Now I'll come to you, Mr. Roy. You keep saying an employer-sponsored plan doesn't give the employee choice. But I would ask you this. Aren't there employer-sponsored plans that give and could give employees a choice over their health care decisions, if structured properly?
So there's a couple of points to make in response to that. The first is that
I don't have a lot of time,
nobody's talking about tax increases. People are talking about letting patients control those dollars themselves, increasing their take-home pay.
I know that, but
letting
let's
them
get back to it.
decide what they want to fund. On the issue of choice for health insurance plans,
If the plan is structured properly.
employers can decide whether to offer one plan or two plans or three plans, but shouldn't workers have the choice to choose between their employer-sponsored plan and 100 different plans that are out there independent of their employer?
They can
if
do that
want
right
to?
now. They can do that right now.
It's much harder for them to do that because the inequities in the tax code make that much more
They
expensive.
can do that right now, but I guarantee you, if you talk to the employees, see, this is what happens. The American people get frustrated with us in Congress because they want us to listen to them.
I appreciate the panelists here today. I wish you had a chance to actually answer questions instead of being lectured to, but because I guess this is a hearing. But in any event, look, I thank you for your work, and I know one thing. When I go back in my district and I talk to my employers, Obamacare's not working to them, and the frustration level is the highest I've ever seen. 8% costs per year in increase, but I also have questions about how we work this system to try to, so I'm going to ask 4 things, if you can address them as best you can. How do we start, if we're going to do some sort of a cap, and it's designed to make it more available to everyday people, not just to the benefit of the more wealthy members in that. So if we try to create caps, how do we keep the young, healthy employees inside that system? My second question is, if we're going to create a tax system that does some kind of a refundable tax credit, how do you deal with people who are families that don't currently have access to employer-sponsored programs? And what do you do with those who have an income level below, the 300%. A third question that my colleague talked to, how do you make consumers understand what to buy when they have a doctor tell them they're sick? First, they're sick. Hard time to make a lot of choices. Second, you don't understand what you're buying. You're being told, you gotta get this test. And then the last question, I'm throwing a lot at you if you have it. I'm anxious to hear us make, but how do you know an employer isn't going to keep the savings themselves and not pass it on in the form of wages that'll increase? A lot of questions, but if you can help me.
Those are all great questions. I think you've asked the right questions. So on the issue of whether the employer will keep the money or raise wages, the economic literature is overwhelming in indicating that there is an exact one-to-one correlation between, because it's overall compensation the employer thinks about, and it's a competitive market, right? If you want to retain those workers and not lose them to a competing firm, you got to pay them what the market's paying them. And so if healthcare costs go down, the cost of insuring your workers goes down, that gets returned to workers in the form of higher wages. So we can be optimistic about that. On the question of patient choice and how if you go to the doctor, you don't actually know, the doctor says you're sick, how do you deal with that? It's a classic problem in healthcare. There's a flip side to that, which is a lot of times you as a patient know a lot more about why you're sick and your family history and your background that the doctor does, who's just glancing at your chart, has forgotten a few things, your medical records are all over the place. So there's asymmetry in both directions. And the more the consumer is in charge of his own healthcare dollars, the more that doctor has an incentive to be really responsive to that patient and that patient's needs and that patient's unique medical history. And that's what our current system works against. And so, if I've missed anything that you've addressed, please.
Well, no, I asked two other questions. I want to know about young, healthy employees. How do you keep them in if we cap this
Right.
system?
So the issue of whether the young, healthy employees will withdraw from employer-based care and go off shop on their own, you could see that to some degree, but you could also see a lot of people stay. And the reason why they would stay in the employer-based system is because of the economies of scale that come from a large employer or even a smaller employer purchasing health insurance in bulk for a group of its employees and having that negotiating power that comes with that versus being an individual shopping for coverage. So I think employers should retain some confidence that they have a lot to offer to that employee and they can provide other incentives to say, hey, we want you to stay in our risk pool. Here are some other things that we can offer you that if you bought insurance on your own, maybe you wouldn't get as good of a deal.
Okay, I wish we had time for follow-up questions, but I wanted to get my fundamental questions answered. And the last one was, how about a refundable tax credit for somebody that's not in an employment situation?
That's essential. So if you only have a non-refundable tax credit, then for people who don't have income tax liabilities, they can't get the financial assistance they need. So refundable tax credits are a very important part of equalizing the tax treatment of health care.
Thank you. Mr. Holding, you recognize.
Thank you. Mr. Roy, in your testimony, you stated that reform should give workers more choice to purchase the kind of health coverage that is affordable for them and their families. But unfortunately, many of the new requirements of Obamacare have made employer-sponsored coverage increasingly unaffordable with higher deductibles, premiums, and cost sharing. And employees are also presented with fewer choices, as we've discussed, when it comes to employer coverage. So rather than dictating exactly what benefits must be offered, would it make more sense to allow employers to provide a defined contribution to their employees so that they can shop around and find the products that meet their needs a little bit better?
Absolutely. That would be a tremendous innovation in the delivery of health insurance in the employer market. You have a defined contribution that they can then say, look, if that, let's say it's $5,000. If I want to spend $6,000, then I can do that with my additional funds. If I like the $5,000 health insurance plan, let me buy whatever we want. There's an intermediate a way of getting there, which is private health insurance exchange that some large employers like Walgreens are using to say, we're going to give you this much money, buy whatever health insurance among these 10 plans that are on the exchange. There are a number of people working on improving that modality for delivering health coverage to the employer market.
Well, defined contributions are pretty common practice in the world of pensions.
Yes.
But not health benefits. So is there something in the tax code or federal law that treats defined contributions differently than defined benefit plans?
Yes, unfortunately, if you just give them the money to buy whatever health insurance they want, it doesn't qualify for the employer tax exclusion, except in these private exchange contexts where you can convert it in a certain way. With the self-insured population, you have a little bit more flexibility than through the conventional employer tax exclusion.
So do you think that treating defined contributions in the same way we do defined benefits under the tax code would help to make the health care cost more manageable and predictable for employees? And similarly, do you think it would give employees more flexibility in their insurance coverage?
Absolutely, and there's been a lot of concern expressed today about if you reform the employer tax exclusion, would that disrupt coverage in the employer market for those who prefer it? And one of the best ways to ensure that employer-based health coverage continues to be robust is to give employers exactly the option that you're describing. To say, you know what, we're going to get out of the business of picking the health insurance plan for you, but we're going to be allowed to have a defined contribution, which then you can use to shop for coverage you want. Because that's a benefit that employees would love to have and would be loath to give up.
Now, importantly, on the flip side, do you think this would create incentives for insurers to compete for this business, correct?
Absolutely.
And competition ultimately would drive costs down because your insurers are competing, correct?
It would drive costs down, and it would also improve quality and customer service because, again, insurers would have to compete for your business.
Thank you. Mr. Chairman, I yield back.
Can you talk to us about what we can really be doing in terms of focusing on that flexibility so we don't have the job lock, as it were? Mr. Roy?
Yeah, so as both of us described in our prepared remarks, if you gradually cap the tax exclusion in a way that's revenue neutral, so it would involve no tax increase on any worker relative to what current law is, you give people that flexibility to opt out if they want to and shop for coverage on their own. And also, if they change jobs, they own their own health insurance plan, just like with auto insurance. Your auto insurance doesn't change when you switch jobs. It's your auto insurance, your life insurance, et cetera. Same with health insurance. It should work the same way. You should be able to transition. You should be able to continue your coverage, and it shouldn't have to be sponsored by the employer to do that. And one mechanism to do that and integrate it into the employer-based system is what we were talking about just a minute ago, which is to have a defined contribution at the employer level, which then the individual can take and use to buy the insurance and keep the coverage as he changes jobs.
I'd love to hear other responses, but my time's expired, Mr.
Thank
Chairman.
you, Mr.
Thank
Dole.
you.
Mr. Rangel, you're recognized.
Thank you, Mr. Chairman, and let me thank the panel for your patience and indulgence in coming here to share with us. Mr. Roy, facetiously, Dr. Price and I said we will adopt your policy, but I would be serious to find out, is it at all possible for you to present the plan that you had to us for us to look at, and how soon could we get it?
I would be happy to do it at any time that's convenient to you and your office, Mr. Rangel, at any time that's anyone in the committee or anyone in the Congress.
Would you send it to us directly, and then I would arrange with Dr. Price and others to be able to discuss it, because it pains me to have struggled so long for expansion of health care to find people that would be anxious to repeal it and not to have a plan to suggest how the vacuum will be filled.
Absolutely, and you know what I would say, Mr. Rangel, is that I've reached out many times to Democrats, both in the House and the Senate.
No, you don't have to reach out any further.
It's sometimes very difficult.
You also are a journalist, right?
Say that again?
You are a journalist as
Yes.
well as... You can prepare the press release now that I have said that I am anxious to see what's on your mind, because with all of the activity on the floor to repeal the Affordable Care Act, I haven't seen an alternative, and you are prepared to show that to me. Now, you're not a health care provider, are you?
No, I'm...
But you are considered a expert in delivery of health care, aren't you?
Well, I will defer to this committee that invited me here as to whether I have expertise or not.
You have provided this advice to Governor Mitt Romney, haven't you?
I was an advisor to Mitt Romney in the past, yes.
And as well as Rubio, you
Yes.
advised him, and Nick Perry.
Yes, sir.
And so, in addition to an expert in healthcare, you also could be considered a political analyst in terms of providing political advice as relates to healthcare. Is that true?
I provide policy advice, not political advice.
But you have given a lot of policy advice to outstanding Republican politicians, right?
I'm happy to give policy advice to anyone who asks, and it's mostly Republicans
I
who
know
ask.
you would. You do get paid for giving advice, don't you?
No, I was a volunteer on.
Have you ever been paid to give an advice?
Have I ever been paid to give policy advice?
Policy advice as relates to health care.
Well, I'm an employee of the Manhattan Institute, so I'm
Okay,
in that
well,
capacity to do research
so
on
what I'm
healthcare
saying
policy.
is, of course, you would welcome giving advice to. No Democrat have accepted your services.
But I would be eager to
Okay,
provide them.
now, you mentioned, what group did you mention? The Financial Institute? Are you with them now?
The Manhattan Institute for Policy Research.
Did
That's
you-
the
are you with them
nonprofit
now?
think tank. Yes, I am a senior fellow at the Manhattan Institute.
Did you ever work for J.P. Morgan?
I did many years ago, yes, before I started working in healthcare policy.
And when you went to work for healthy policy, did you form or become partner in a firm called Torreya Funds?
No, I was not a partner in Torreya.
Were you a part of Torreya?
I was an outside consultant. I worked with some of their individuals.
So you gave advice to Torreya?
I was a consultant, yes.
Does consultant mean giving advice to them?
Sometimes, yes.
And is Torreya a hedge fund organization?
No.
Do they advise in hedge fund organization?
No, they mostly advise companies, such as biotechnology companies that are trying to develop new therapies.
Have you given advice? Have you been described as a advisor to hedge fund investors?
Yes, I've sometimes given advice to investors, as I give advice to policymakers and other
But
people
since
who
your
are.
specialty is in healthcare, would you have concentrated in giving investment advice or policy advice to hedge funds that are concerned with the providing healthcare? That's where your expertise is.
I'm not sure if I understand the question. If the
I'm
question
trying
was,
to connect you with hedge fund providers. That's what I'm trying to do. That's
That's become clear, Mr. Rangel.
And
Yeah.
so I don't know what it is. What part of my question is it that you don't understand?
Yeah, so
I want to see
after I
where you get your money. Hold it. You're not a doctor. You're
I
not
worked
a
as an
health
investor.
Please, just 1 minute.
Sorry.
You're not a doctor. You see, you took my time away, but perhaps the chair might afford you some time to separate yourself from hedge fund investors as relates to healthcare.
My policy advice is entirely independent of my previous career as an investor in the healthcare system.
Thank you. Mr. Roy is a acknowledged expert, incredible witness on healthcare reform. We welcome your attendance today.
Jonathan Gruber testified that, you know, when he was helping design the Affordable Care Act, that the Cadillac tax was specifically designed to increase the cost of employer-provided insurance over years and thus force everybody into the exchanges. And what I'm asking you is, if the Cadillac tax works as Mr. Gruber designed it and forces all the employer-provided health insurance becomes so expensive that people can't do it, and all your members are transferred onto the exchanges, are they going to be happy with that, or are they going to be disappointed?
Well, first of all, I think Gruber's wrong.
Well, he designed the plan.
There's some controversy over that. But he's wrong in terms of what would happen. What would happen, in our view, excuse me.
Mr. Roy, is Gruber wrong or is he right?
Gruber wrong about what specifically?
That the Cadillac tax was designed to make employer-provided health insurance more and more expensive so that people would eventually be forced onto the exchange.
I don't believe he said that the Cadillac tax would make health insurance more expensive, that people would go on the exchange. I don't believe he said that.
Employer-provided insurance.
I think he has stated that the Cadillac tax was designed to, because it's back-loaded in terms of the way it appears, the way it comes in, that would be less transparent.
Well, it's backloaded so people won't figure it out till years later. He said the American public was too stupid to figure it out. That's exactly
Its convoluted design was what he was celebrating because people wouldn't understand how it worked.
It doesn't apply until 2018, and then it's indexed based on inflation, not on inflation in healthcare costs. I yield back.
Thank you. Mr. Reed, your final question.
Well, thank you, Mr. Chairman, and you are at the end. And I guess this is the penalty for showing up late, and I take responsibility for having the last 5 minutes. First, I just want to make sure this is clear, and I was offended by my colleague on the other side of the aisle who referenced that somehow the Republican agenda is to take away health care for people in America. That's just not accurate, and our committee's better than that, and I will talk to that member personally to make sure that we always raise our discourse, because I think what's here between us on both sides of the aisle is a recognition that the healthcare system is not working in America, and that we have to get to the issue of healthcare cost in particular. And I understand that the heart of this conversation today is about employer-sponsored healthcare. And it is a big change if we go down the path of removing that exclusion in the tax code. And I am very concerned about that. But I'm willing to put all options before us to have a wide open debate in order to make sure that we're attacking the fundamental problem, and that's healthcare costs and accessibility for our fellow American citizens. That being said, we are 6 years into this experiment with the Affordable Care Act, Obamacare. So let me ask you a question. Who's been to the doctor in the last 60 days on the panel? Anyone else? How much it cost, Mr. Roy? How much it cost?
I don't know.
You don't know, right?
Well, because it was covered by insurance, and I don't really get a bill that explains to me how much it costs.
So each of you had indicated that you have have insurance through your employer. What'd you pay last month for that insurance?
I don't know.
Mr. Kreisberg, do you know?
The insurance plan that I'm covered in costs, my employer pays for it. Costs probably about
How much it costs
$2,500
you?
a month.
How much it costs you?
I don't pay a premium.
You're 100% covered by your employer. And
Yes,
it's
I am.
approximately how much by your employer?
Approximately, I would believe somewhere about
You would
23
guess,
to $2,500 a month. Yeah, I'm
There you
guessing.
go. You're guessing, right?
Approximation, yes.
Does that not illustrate the point? You are three leading experts testifying before the U.S. House of Representatives Ways and Means Committee. Is this not the point?
Absolutely, and it's a question I often ask.
You don't know the answer to that fundamental question. And does that not, in a large part, drive the problem we're facing in America's health care?
I think your conclusion is wrong from the point
The
you're
lack
trying to
of
make.
transparency by you as an expert, not knowing the cost, not knowing how much it costs you in the system is not causing the problem, or at least contributing? Would you concede that it contributes to the problem?
The problem isn't what consumers know about costs. The problem is what the costs are. The costs, as you're trying to point out, the costs are paid.
Mr. Kreisberg, hold on. I've waited 2.5 hours to have this time.
Yeah.
This is the issue. There are, in my mind, two tools that we can use to control costs: market pressure driven by people, or government mandate driven by DC. Are there any other tools out there that you can think of? I see a bunch of no's across the table here, right?
Yes.
What we're trying to do is to say to the American people, we stand on the side of you. We stand on the side of a market. Now, you may not agree that it could work in the healthcare industry, and there are going to be situations where a true market does not exist in healthcare. I get that. But our fundamental tool that we're trying to use is market-driven pressure to drive the cost down. Other side, when they celebrate the Affordable Care Act, is saying government is going to drive those costs down. I'm concerned about that, as well as hundreds of millions of people across America that say, if a government can tell you how we're going to drive that cost down in a personal transaction such as healthcare, that is an extensive, big government type of power being exercised over us. So I'm open to trying to empower individuals to have that market-based pressure, giving them their money in an employer-based situation. I have great concerns about it. I will be perfectly honest with you, because we have all become accustomed to it. But I do understand the power of what that would represent. And what we're trying to do, is that not what we're trying to do by recognizing the exclusion and saying, if we give that power to the employee, that they may be in a better position to determine and put that market pressure on the system to drive the cost down? Is that what we're trying to get to, Mr. Roy?
I thought you laid it out beautifully.
Well, thank you. As we end on that, I will yield the balance of my time, and thank you to the entire panel for that exchange.
Thank you, Mr. Reed. I'd like to thank our witnesses for appearing for us today. The question is, as we preserve the incentives for employer-sponsored health care, can we update this tax incentive, provide more options in a 21st century world to workers at work or those who want health care outside of work in a way that works for their family and their lives? And we got great testimony and very constructive dialogue today. I appreciate the witnesses. Please be advised, I would like to submit for the record a letter from the Congressional Budget Analysis by Congressional Budget Office that shows that drug price savings aren't obtained by negotiating with Medicare. Please be advised, members have 2 weeks to submit written questions to be answered later in writing. Those questions, your answers will be made part of the formal hearing record. With that, again, thank you for being here. The committee stands adjourned.